A quick background, I qualified over 10 years ago, predominantly worked in emergency medicine, and really my experience is actually seeing and treating the tail end of chronic disease. So seeing people present with heart attacks, strokes, numerous cancer presentations, and all the rest. And all of it really is linked back to unmanaged chronic disease conditions like obesity. And that really gave me a good insight into the opportunity there was for us to do things better and to offer people who genuinely wanted to manage their health better, to give them an opportunity to have that medically led service. And that's really the origins of Beyondbmi. And today I am joined by another one of our founding members, Prof Alex Miras. Prof, if you want to give everybody a bit of a wave, just to identify yourself there. Prof Miras comes to Beyondbmi from Imperial College London, where he served as a professor since 2002. And before that, he's worked in various academic and clinical roles in the University of Toronto, Harvard School of Public Health, the University of Cambridge. And we're really lucky because he's published a lot of his research in some of the most prestigious journals in the world, and is currently now also professor at the University of Ulster. So he's been really deeply involved in the planning, the implementation and the delivery of Beyondbmi. So, you know, a really great person to have today to answer all the questions. So speaking of all the questions, many of you have actually already submitted questions, and you'll also have an opportunity at the end to kind of to ask more questions if we don't get to it. But you know, there was some very, very clear themes coming through in the questions. So you know, on the medication side of things, the three main themes that we noticed really were around people talking about, you know, suitability, who's suitable for anti-obesity medications and who isn't, and why. Long-term use, you know, do you need to take them long-term? What happens if you stop taking them? Are they safe to take? Expectations, how quickly do you lose weight? How quickly can you expect to lose weight? Does everybody lose it? Does some people not? Why do some lose weight and some not? And then on the program side of things, you know, asking questions around Beyondbmi, you know, how exactly it works as a program, what happens after you lose the weight, and some really great questions there. So to put a bit of shape on today in the present and the webinar, what we'll do is we'll start off by you know, so answering some of these questions around the medication side of things. And listen, if you've got any other questions that are burning, just throw them into the chat function, and we can try and get to them at the end. So to kick things off, Alex, I'm going to throw this first one to you. There's a question that's come in around suitability for medication. So what level of overweight do you need to be considered for obesity medication?
Before I answer the question, can I just make an overall comment? Because if we just agree on some basic concepts, I think it will make the conversation a lot easier. So can I start by saying that overweight and obesity are medical conditions for most people. And the definition is excess weight that affects health. So these medical conditions are no one's fault. And we know that our own biology, the biology that controls our appetite system in the brain, is determined or even predetermined a lot by our genetic makeup. So we all live in the same environment where food is very widely available, it is tasty and cheap. Yet some of us are on normal weight, some of us are underweight, and some of us have got high body mass indices. So it is not the environment that is to blame for that. It is our biology that determines where we sit in this distribution of weight in the population. Okay, so if we start with this being a medical condition, with, of course, environmental influences, but heavily a biological condition, a bit like high blood pressure and high cholesterol, then the discussion becomes easier. So if we go now to more specifics, Harriet, the eligibility for medications at the moment, the rules are that people who have a body mass index over 27 and have got one obesity or overweight related complication, or even people who have got the body mass index of over 30, even without a complication of obesity, they are eligible to have these medications. A small thing to say there that people from specific ethnic backgrounds, like South Asians and Eastern Asians, that BMI cutoff can be reduced by 2.5 points.
And Alex, what's the significance of assessing eligibility based on complications? So why do we even talk about complications?
Yeah, so this is not a Beyondbmi is not a service which is aimed at aesthetics. So we're not a cosmetic service. Of course, weight loss carries with it important health gains, but we are mostly focused on the gains and less on the weight loss itself. So we want to take people that have got complications, of course, making them eligible for the treatment. And we want to either put these complications into remission, or which means that they are now sleepy, they are not bothering the person anymore, or we just want to make these complications better. And in some people, we may just be able to do that. In other people, we may be able to, as we say, put these complications to sleep.
And Alex, just moving on from that, another question that's come on is around the medication and how exactly it works and where in the body it works.
Mm-hmm. That's a great question, and I get that question a lot during the consultations. It's interesting how many people are interested as to whether these medications increase the amount of energy that we burn. So how much did they increase metabolism, as it is called, commonly called? And actually, at the moment, we do not have medications that change our metabolism. But what all of these medications do, certainly the ones that we have now, apart from Orlistat, which is slightly different, they all work in the appetite areas of the brain. These are the areas that control our hunger and our fullness when we eat, and eventually, therefore, our body weight. Therefore, what these medications do is that they reduce hunger, they increase fullness after a meal, and as a result, people eat less. That is what causes the weight loss.
And Alex, we often have people that will say things like, but I don't feel like I have a big appetite. I don't think appetite is my problem. So
exactly right.
What does that mean for people who are living with obesity? How do the medications work for those subset of people?
Yeah, and that is a very good question, and one which is difficult to answer. But what we do know is that for whatever weight or body mass index someone has, they are eating enough. It doesn't matter how much that is, but they're eating enough to keep stable at this body mass index. So what these medications will do is whatever the food intake is at that body mass index, they will reduce it further. So I'd never go into discussion about, but I'm not eating, I'm not snacking, etc. These all of the things may be completely true, but if the medication is going to work, it is going to reduce the amount people eat, even though they feel that their appetite is not the problem.
Very interesting. And I suppose that's where the dietitian is so important in all of this really as well, because, you know, the dietitian is there to make sure that as your appetite is coming down and you're now eating less food, that the food you are eating, the quality of that food is going up. You know, and as we know, it's not just about weight, it's not just about the number on the scales, it's about your body composition as well. What is your body made up of? Is it predominantly fat mass? Is it predominantly muscle mass? And the impact that has on your day-to-day life, your energy levels, your functionality, all the things we actually care about, you know, your ability to get around more easily, live your life, you know, essentially enjoy yourself. And that's why, you know, we often we'll talk about not just looking at the number on the scales, but, you know, all the other health gains as Alex referred to.
So what I'll say, if I may, Harriet, on this one, is that what the dietitian and the health coach are doing is, at baseline, they are addressing the non-biological, so the environmental influences on our body weight. So they're going to assess things like our nutrition, they're going to assess our sleep, stress levels, etc., because these are things that we can attempt to change in the environment, and they're completely unrelated to our own biology. So by having a team that addresses all of these factors that contribute to obesity, we have got an overall better result. And when it comes to now the complications that you mentioned, all of the patients that go through the system, when we assess them for the first time, we will go through a very standard way of assessing each and every complication of obesity. We do that, as you know, using a system which is standardized. And what we want to do is, after 6 and after 12 months of treatment, we want to see not only the weight dropping, but we want to see the complications, as I was saying earlier, either improving or even going into sleep, into remission.
Absolutely. And listen, Alex, we've got a really good question here, which is a little bit long, but I think that the length of it will actually help, to contextualize the question. So one of the questions is around a lady who's actually currently on the program, and she's written in to say, according to the scales, I'm no longer in the obese category, and all going well, I hope to get to a healthy range in the coming months. Am I correct in saying I still have obesity, the disease, even though I am not obese as per the scales? I'm thinking it's the same as saying I have high blood pressure, which I do, but due to medication, it's in the normal range if you measure it. Will I always have obesity, or is there a way for the hypothalamus to learn the new appetite set point? At some point, it learned the wrong one because I wasn't overweight or obese my whole life. Or would it be more like a thyroid problem where once it goes wrong, it's essentially broken and can only be fixed with medication or surgery?
That's a great point, and I'm very interested to hear that this lady has reached what sounds like a normal body mass index. So the first question is, what is it? We keep calling it set point. What is this set point? Set point is, to put it simply, what our weight is predetermined to be based on our biology. Okay, so generally speaking, people who have obesity, their body mass index, their weight, let's give you an example, will be 100 kilograms. Say that this is what they are meant to be based on their biology. So what these medications do is they reduce that set point by about 8-10% or so that people can now, on average, maintain a new set point, which would be approximately, say, 90 kilograms, okay? In some people, depending on where they start when it comes to weight, in some people, it might be possible with the medications to reach a completely normal body mass index, a completely normal weight, like this lady that you are referring to. So the first question is, have we improved this lady's obesity-related complications? That's the first thing to say, which is really important for us. Number two, the question is, does he have still the condition of obesity? And the answer is yes. As you said very rightly, someone has got the condition of high blood pressure, but when it is treated with medications, it is still there, but it is well controlled. Okay, but if we stop the medications for high blood pressure, then the high blood pressure will come back again, the hypertension will be there, and that's how we know that someone has got the condition of hypertension. Exactly the same happens with obesity, that if the weight is controlled with medications, the person still has obesity, but it is well controlled. If the medications are stopped, the weight goes back up, and the disease of obesity relapses, as we say. I do get asked this question about, could we be trained through the medications so that our behavior is maintained, so our behavior in terms of our food intake and our food patterns is maintained even when we stop the medication? And I get these questions from many people, including some very smart colleagues that I'm treating. And the answer is, in most people, not in all, But in most people, this unfortunately doesn't happen. So about 90 to 95% of people, when they stop taking the medication, they will regain all of the weight that they have lost. There is a small percentage of people that manage to maintain it even without medication, and we don't know why they are able to do it.
And I think it's a really interesting point, because I know conceptually that when we think of that, some people think, oh, but what's the point then? What's the point if it doesn't, if it doesn't, my weight won't stay down without taking medication. But we would never think about a diet like that. We would never think that, oh, a diet will get us to a certain weight and then we stop the diet, because there is no solution out there, not a dietary one, not a behavioral one, not a medical one, where not even a surgical one. If you have bariatric surgery and then you reverse that bariatric surgery, that weight loss surgery, the weight will come back. So there is no solution in the world that exists that if you stop taking it, that that you can expect to stay at that end result. And I think that's a really important, transparent point, that every single doctor, every single company that is claiming to be able to treat weight or claiming to be able to treat obesity should be very transparent and open with people about, because that currently doesn't happen. You see people saying, oh, once you do this diet, you're sorted. That's just not the case. And biologically, that's not the case. So that's a big part of weight management, isn't it, Alex? It's managing expectations and being really honest and transparent about what people can expect, so they can readjust to this new way of thinking.
You're right, people get uncomfortable many times when I introduce the concept of taking something long term for obesity or overweight. I can understand why they become uncomfortable, but our job here is to make people comfortable with that idea. So I hear the stories of people telling me, oh, I've been struggling with this since I was 11 years old, and now they're 50. Well, 4 decades of struggling means there's something wrong. Okay, and the next 3 decades, or however someone is going to live, are going to be the same. This struggle will not disappear. So that's why this is a treatment, whatever treatment it is. As you're right, it can be nutritional treatment, it can be physical activity, pharmacological or surgical. It has to be there long term, because this is a long term problem. And as unpleasant as that might sound, it's better to accept it and then move forward. And in fact, for people that don't accept this at the beginning, I have a feeling that they will not necessarily do very well in the future. So we now know that there are a lot of people who stop these medications at some point in time. Most of the time, this is because they have not been told this very simple method at the beginning, and they have not become comfortable with this. So it's number one, being told, and number two, actually believing it. Okay, so I think this is what differentiates perhaps some of the messages that we give.
Yeah, and I think that shouldn't be something that people get despondent about or feel guilt or shame or that they've done anything wrong. This is just pure biology in play, and it's just how our bodies work. But it's certainly a really interesting part and a really important part that we need to get right in order for people to have long-term sustainable weight loss, which is ultimately what we're all striving towards. So just on that point, Alex, somebody wrote in to ask about the long-term implications of medication. So should I be worried about the long-term effects on my brain or my gut?
Good questions, very important ones. We have been using these medications to treat diabetes for the last 16 years, or we have been using specific classes of these medications to treat diabetes for the last 16 years. And if a medication has survived 16 years, especially in people with diabetes who are generally high risk for heart disease, cancer, etc., then they have certainly stood the test of time. So I have no hesitations based on the large amount, the wealth of data that we have on these medications in recommending them long term. What can go wrong? Very few things. As we know, initially people can have some side effects, and most medications have some kind of side effect. But the good news about these medications that we're using is that these side effects are transient. They're usually there in the beginning, and with time they disappear. The worst thing that can happen on these medications are two things. One thing which is called pancreatitis, which is inflammation of the pancreas, and this happens with a specific group of medications like semaglutide and liraglutide. And the other complication is called cholecystitis, which is inflammation of the gallbladder. This inflammation of the gallbladder can happen after any treatment for weight loss. It can be nutritional, it can be surgical, and it can also happen with medical treatments. But these two side effects, the gallbladder, the pancreas one, are very rare. They happen in less than 5 in 1,000 people that we treat. Again, these are all important points to make, as you say, in order to be completely transparent in our consultations. And the final thing to clarify about these medications is that they do not cause diabetes. They prevent diabetes from happening. And number two, they do not cause in humans any form of cancer.
So where did that whole cancer piece come about? Because I know some people are concerned about thyroid cancer, for example. Where did that come from, Alex?
It came from a study that was done probably around 15, 20 years ago now, when they were testing these medications like semaglutide and liraglutide in mice. And what they found is that some of the cells, some of the tissue of the thyroid of those mice increased in size. Okay. The legacy of that is that we now have to, in clinical studies only, monitor for any evidence of growth, abnormal growth of the thyroid, only in the research studies. Now, as I was saying, all of the data that we have from the last 16 years on this group of medications clearly tell us that humans do not develop thyroid cancer. They don't develop any form of cancer. And the reason why that is because the thyroid of humans is very different from the thyroid of mice. And indeed, there are now thoughts, if not studies, that are using these medications to prevent cancer or to prevent the redevelopment of cancer, the relapse of cancer in people who have been treated before.
And that's such an interesting point, actually, around, risk reduction in cancer, because, I know some of our colleagues down in Maynooth are now looking into the use of these medications to reduce people's risk of cancer and as a potential treatment. What's the underlying biology of that? What's the underlying biochemistry? How are we starting to hypothesize that this can actually reduce risk of cancer?
Okay, this is a difficult one, but I will attempt to answer it. So there's a number of mechanisms. The two important ones are inflammation. So we know that inflammation in the body is related to cancer, and we know that obesity itself is a state of inflammation. And we know that obesity is one of the strongest risk factors for the development of cancer. Therefore, by reducing inflammation throughout the body, but also in specific organs, we can reduce the development of cancer. Another mechanism is what we call insulin resistance. There are some usually female-related cancers, like endometrial uterine cancer, which are related to resistance to insulin, which can be because of diabetes or it can be because of obesity. And therefore, when we reduce that insulin resistance, the risk of developing cancer decreases, or the risk of redeveloping cancer after it has been treated before decreases. So these are some of the key mechanisms, but this is a whole new area of interest. And let's also not forget that a lot of the data that we have come from bariatric surgery. And surgery has been shown to reduce the risk of cancer incidence, development of cancer, by 40%, 40%.
Wow.
So now that our medications, and we will talk about that, are evolving, and they will be able to achieve similar weight losses to surgery, why not expect something similar?
Yeah, I mean, that's fantastic. And I think that the key line that you pulled out there, Alex, was obesity is a state of inflammation. And I think many of us don't think of obesity as that. But when we do think about that, it helps us to understand that actually this is a multi-systems disease. It's affecting every single system in our body, our brain, our liver, our kidneys, our skin, everything, because having that inflammation all over our body is obviously causing disease. So I suppose moving slightly on from the medication side of things, I'm going to throw a kind of a psychological one in here, but somebody has written, would medication help when I feel it's primarily a mindset issue that is keeping me on a yo-yo cycle?
Okay, so these are some nice terms. Let's start with the mindset. It depends what we define by mindset. Okay, to me, I'm not a psychologist, but my interpretation of mindset is that these are the brain mechanisms that contribute to someone putting on weight. So what are these? What can form part of these mindsets? Mindset can be just a feeling of hunger, just putting it simply, feeling of hunger, feeling of fullness, simple things. But then we start moving into more vague things to describe, which are cravings. Okay, so indulgence by energy rich food. We all indulge in energy rich food, but some of us indulge more than others. Okay, and those that do have got usually a biological predisposition for that. Then we have got things like emotional eating or stress eating. So how we behave in response to environmental stimuli, and how we end up going to food, binge eating sometimes, etc. Also, another concept that fits into that mindset that this patient has talked about is the fact that we really want to go on with the diet, we really want to try, we really want to reduce our caloric intake, increase our physical activity, but many times what we are trying to achieve in terms of caloric restriction in particular can be unsustainable. Okay, and that's why in this program we never tell people to go on very low or low energy diets, i.e. 100 kilocalories per day, because it is impossible for everyone in this room to be able to maintain an 800 calorie diet for life. Okay, we can do it for a short period of time, and that would cause weight loss, but it will be transient weight loss. It is not sustainable. And therefore, these recurrent episodes of dieting, losing weight, eventually, this yo-yo dieting has been shown to, in effect, cause weight gain in the long run and sabotaging someone from losing weight and making it more difficult for them to lose weight the next time they are trying to achieve that. So, and to finish off, this is what medications can do. They change this mindset that this person was talking about, so that all of these eating behaviors are reduced in intensity.
Absolutely. And I think one term that keeps coming through from a lot of our clients, Alex, is people say things like, for once, I feel normal. I have a reduction of what they describe as food noise. I don't feel like I'm being constantly tormented by this, internal voice telling me, I need to eat again, and I need to, I need to finish what's on my plate. And for that to just disappear must inevitably have a huge impact on someone's psychology. So it's that kind of overlap, isn't it, between the psychological and the biological side of things.
And it's very interesting. I'm just going to throw a point, which is a quick one, that I have had treated patients in the past with these medications who did not lose a single kilogram. So I was very ready to say, oh, we need to do something else. And they will say, no, 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 thank you very much. I said, what, you want to continue? He said, yes. Why? Because I am relieved that I do not have these symptoms of cravings and hunger. That was an eye-opener to me, how just by treating the symptoms without causing weight loss is for some people so important.
Yeah, absolutely. And I suppose, on that point, I think, we talk about the mindset side of things, and that's why with the program we have taken that massively into account, because we know there's a very, very strong overlap between eating disorders and obesity. In fact, we know that almost 40% of people living with the disease of obesity will also have some kind of clinical or subclinical eating disorders, whether that's binge eating disorder, avoidant restrictive food intake, bulimia. And so really some of that stems from relationship with food, and it could be that we've grown up in a home where we were always told to finish what was on our plate, or whether when we were very sad we were given treats, and that gave us that emotional connection towards food, that when I'm sad I eat food and food makes me feel better. And I think there's very few of us can claim to have a fully detached relationship with food where we don't use it for some kind of an emotional reason. It's when that flips into a disease state where it's causing us some kind of reduction in our quality of life that we know we need to do something about it. And that's why I suppose having the support of health coaches, and increasingly we're going to be bringing psychology into Beyondbmi as well, to really help people to reassess that relationship with food. But again, Alex, would it be fair to say that psychology in and of itself is not a solution for weight loss, meaning psychology in and of itself is not a sustainable way to lose weight?
It would be, but for a very small number of people. Okay, for the vast majority of people that we treat in the program, a psychological intervention addresses some of the psychological causes of the weight. And as we said, there are eating behavior, habitual causes into that, nutritional causes, there are psychological causes, physical activity causes, stress, sleep, etc. And what the psychologist will do is address some of those, so that by itself, that will cause some weight loss. But if you combine it with a nutritional support, that will cause more weight loss. And if you combine it with the medication, then we will have an even better effect. So what we are learning with obesity is that all of the way that the field is moving is towards combination treatments, and the combination can be, can be whatever you want it to be. It can even be using surgery, bariatric surgery with medications, or using nutritional therapies with psychological therapies only. It depends on what the person responds to. Some people will respond just to nutritional, as I was saying, some to just psychological, but most people, the vast majority, will need a multimodal, a comprehensive, multidisciplinary approach to bring all of those drivers of weight down.
So that's a great answer, Alex. So moving now more on towards the kind of the long-term viewpoint here, which is obviously super important. Someone has written in to say, what do you think is key to making sure that the weight stays off after a year?
So as we were alluding to earlier on, the most important point people can do is stay on treatment. Stay on, if they are taking the medication, stay on the medication. If they are on a nutritional therapy that's working for them, stay on the nutritional therapy. Or if you are in a combination of treatments, stay on that. That's the most important point. And let me make another important point. I don't know if I have made it already. I tell people that when we start them on the medication, they are not going to stay on that specific medication for life. They are going to be changed. They're going to be given what is the best medication at the time, and these medications will continuously change. So that people are not stuck with a specific pill or injection. They need to be, the treatment is evolving, and the treatment that we are offering to the people will evolve over the years.
And on that point, what I suppose, you know, so if somebody continues to take the medication after a year, let's say, what are the other areas of their life that you maybe feel they might need to also concentrate on or pay attention to that would help them to maintain that weight loss? So I know, for example, in you know, the current thought around obesity and weight maintenance is very much around what we would call now, is it life maintenance is the term that we're using?
Mm-hmm. That's right. So you either continue, well, you have to continue with whatever we have offered that works. If it works, you carry on with that. But then we should not forget to keep exploring things that have not been addressed in order to enhance the weight loss. And most of the times, this will be what we would call environmental influences, not so much biological, because those we will address with the best available medications at the time. A very important um, intervention and issue that we need to be thinking more and more, especially now that our medications are getting more and more potent, is, as you Ed said earlier on, the loss of muscle mass. So all of these medications cause loss of fat mass, which is what all of us want. But inevitably, they also cause, to a small degree, muscle mass loss. And muscle mass is really important for health. We want to preserve or even increase our muscle mass as much as possible. This is a new area of interest. And for now, the basic things that we can advise, and the nutritionist will be able to help us more with those things, are to keep our protein intake as high as possible, and to increase our physical activity, and in particular our anaerobic physical activity, in order to address this important point. Because enough muscle is good for health. The more muscle we have, the better metabolic and cardiometabolic health we have.
Absolutely. Just to ask, you know, if anybody, if anyone is kind of, if their mind is running crazy and they're thinking, oh, I've got lots more questions, just don't be afraid to pop them into the chat, and you know, we'll have about 10-15 minutes at the end to answer any questions that are kind of coming to you as you're hearing this discussion. So, you know, Alex, as a you know, professor of obesity and someone who's worked, you know, across the world, multiple different in different kind of different types of clinics. In your opinion, what is the benefit of the multidisciplinary team? And can you maybe talk a little bit about what exactly a multidisciplinary team is, and why it's considered the gold standard really of disease management?
Yeah, so usually a multidisciplinary team will include people who specialize in dietetics, in nutrition, physical activity, psychological support, medical support, so medical personnel, and you know, we collaborate with surgeons as well. Then obviously we cannot operate on the internet, but we collaborate with surgeons, so that if one of our patients needs surgery, we have that discussion with them, and then we direct them to the right channels in order to have their operation done. We're looking after a lot of people, as you know, that are waiting to have surgery, and we're also looking after people who have had surgery and need combination treatments. So again, what the function of and the benefits of the multidisciplinary team is that we address every possible driver for weight gain. And there are many, many, many of those. What we also understand is that obesity is not a single disease. It's not the same disease in everyone. Everyone has got different drivers to their obesity. And we've discussed that many times before, that we thought that cancer was one disease, and it ends up that cancer is many different diseases. So what multidisciplinary team does is it takes someone and understands their obesity and understands what the most likely treatment is that will work for them. And that's what we call personalization of treatment. And it might be the case that we need to push very hard with psychological input and less hard with biological support. It depends on the individual in front of us, number one. The second important function of the team is to assess the patient after 3 months of treatment. It doesn't matter what the treatment is. So that what we thought would work in that person actually does work. And we know that we can decide that after 3 months of treatment, whatever the, as I say, the intervention is. So we are, and we need to be even more agile to changing treatments if the treatments are not working. There is no point giving a nutritional treatment, say a low carbohydrate diet to someone who then comes back after 3 months and they have not responded to that, and keep pushing them that this is what they need to do. We need to be agile and move to something else that for that particular person is going to work.
Yeah, so I think you raised some really interesting points there. You know, the multidisciplinary team being a team that is ultimately looking at all the different drivers of weight and addressing all of them, not just coming at it from a siloed approach. So not just saying, you know, go on a diet or restrict your calories, or not just saying go to the gym 5 days a week. It's coming at it from all the different perspectives and looking at you as a whole person and a, you know, in a really comprehensive way, and approaching it like that, you know, often means that we're leading to kind of better long-term outcomes. Alex, in your opinion, what's the benefit of community? So, you know, one thing that we've noticed with Beyondbmi is that as we've started to build out the community, we're seeing a lot of activity. People are asking each other questions, they're providing advice and support. You know, you're the scientist in the room, you're the researcher in the room, you're evidence-based. Is there any evidence behind community or any evidence behind that peer-to-peer support?
Oh, that's a very difficult question. But traditionally, we know in medicine that for difficult conditions in particular, I mean, you know, if someone has got, like, you know, they sprain their knee, they're not going to form a group about that because it's a small thing. But for chronic difficult conditions, peer support, as long as it is carefully managed, can be beneficial. Even more so for conditions like obesity that are so stigmatized and so misunderstood. We're finally understanding that there are millions of other people that are facing exactly what you have been facing and you didn't know. So understanding that you're not the only one, I think it is a great relief, independently of what effect this has. I think it has just the relief that other people have heard the same wrong things that you have been told, that have had terrible experiences of guilt and failure. I think this is a major relief for this very misunderstood condition. And by the way, we don't understand obesity yet well ourselves. Yeah, we are now beginning to understand it more, which is great. But we really do not understand the different causes of obesity. But going back to the peer support group, I think their role is beneficial. It would be nice if somehow we could measure that in some way, but I'm sure that others have measured it in other areas of medicine and they have found it to be beneficial. However, we also need to be careful as to how this is managed, because sometimes, with the best intentions in the world, people can say things that are not accurate, and that's our role there. We need to be there in order to steer the ship in. It's probably going in the right direction, but we need to make
Yeah.
sure it does stay in the right direction.
Yeah, yeah. I think you're absolutely right, and I think touching on internalized stigma, we do know from our social scientists colleagues that internalized stigma, which is defined as self-blame, the self-critic, the person that says that this is my fault, that actually does drive poor health outcomes. And I suppose if we can try and give people that sense of belonging, that sense of being felt and understood, that really that can help us to reframe how we look at ourselves and reframe how we think about ourselves. And I know, for example, one of our health coaches, Paul, is doing a lot of work at the moment now with mindfulness and self-compassion, which is really, really popular. And whether you're living with obesity or not, it's lovely to take a moment sometimes to have that self-compassion and say, I'm trying my best, I'm doing my best with the tools that I have, and beating myself up and saying things are my fault is not going to lead to a better outcome. So being compassionate with myself is a really good place to start, and that in and of itself is a practice. That's something that a lot of us are not taught. We don't learn that. We're learned to be critical of ourselves and critical of others, and to be taught that practice is a phenomenal addition, I think, to this weight loss journey. So a question has just come in now from someone. Once you've joined the program, are you prescribed and started on the weight loss medications in the first month?
Do you want to answer that?
Sure. So the short the short answer to that is, if you are eligible, yes. The long answer to that is, we will assess people, and it's a very comprehensive assessment. It includes filling out a medical questionnaire. It includes having a 30-minute consultation with an obesity expert. So that's 3 times the length of a GP consult. There is no guarantee that you will be prescribed an obesity medication. And the reason is because you have to be medically suitable, medically eligible, and that it is the right decision, between yourself and the doctor. But what I will say is that we do our absolute best to make sure that the people who are, eligible for the medication, that they would be able to access it. So yes, I mean, if you're eligible, yes. If you're not, no. So I think there was another question that came in here saying, I am ready to stop breastfeeding my 2-year-old to start a medication path for weight loss. However, I'm having a hard time to stop it. Can I start the program or should I wait?
They're having a hard time stopping what?
Stopping breastfeeding, I think.
Okay. The answer is yes. And that we're going to have a bit of a discussion when we meet in person to discuss that. But after the breastfeeding has been discontinued, we can certainly start treatment. The main thing to talk when it comes to women for reproductive age, which is important, is that we generally advise that women do not conceive whilst taking the medication, and certainly they do not continue with the medication during their pregnancies. But we do know that a pregnancy is a driver for weight gain, and therefore we are very ready to consider treatment depending on the individual circumstances after the pregnancy.
Okay. And Alex, if you're somebody who is thinking about getting pregnant, and maybe, for example, you've been advised, from a gynecologist, or you've been advised from an IVF therapy clinic, that weight loss might actually help you conceive. How would you manage a situation like that?
Yeah, a difficult one. It depends on how old the woman is, how many children they have, etc. But yesterday, to give you an example, I had a very difficult case with a lady that has had a number of IVF cycles, and she had not responded to them. She had not been able to embark on a pregnancy, and this was her last attempt, and she had been told that she needs to lose weight. So I tend to be quite aggressive in those circumstances, and what I suggest is, we're going to try the best with weight loss with medications, and I would normally recommend that these medications are stopped, depending on the medication, about 6 weeks or so before for example, an IVF treatment or starting to embark on a pregnancy. So 6 to 8 weeks, I would say, are the minimum that need to be stopped. So this is the time period that needs to be stopped before someone can embark on a pregnancy.
Okay, great. Another question here. Just wondering if you are on other medications, can there be contraindications?
Okay, so the answer in just overall, just to say that the chances of contraindications with the medications for weight loss are very, very, very small. Okay, so certainly when it comes to what we call the GLP-1 receptor agonists, things like semaglutide or liraglutide, there are very, very few contraindications. They are unlikely to cause any issue with any other medications that you might be taking. There is another medication that was used, which is called Mysimba, and that works differently to the GLP-1 receptor agonists. And they theoretically interact, for example, with specific antidepressants. But again, the risk of those interactions is very small. So what we do in the consultations is we discuss those interactions, we discuss how likely they are to happen, and then we decide whether the benefits outweigh the risks. And we also know that these risks exist in the future, but what we do is we inform people to be able to recognize potential interactions and act on them very rapidly so that they do not become problematic. But overall, the interactions between obesity medications and other pharmacotherapy for other conditions, the risk of that is very, very low.
Yeah, I think that's a great point. Like we'd often have people asking, can I take weight loss medications, anti-obesity medications while I'm also on HRT, which would be for menopause, or if I'm also on antidepressants. And I think you really answered that very well. Is that's really why you should be having these one-on-one consultations to discuss the risks, the benefits. There's nothing in life risk-free, but really, it's about managing risk and being able to feel like you're in a position where you're having a fully, you've got all the information to make a fully conscious, educated decision. And it's why it is so important to have that 30-minute consultation with a doctor, because that's your chance to discuss your personal medical history. It's why I worry about some of these other clinics where you can essentially go online and get access to medication without speaking to anybody, because it's just a very it's a very loose way to manage your health, really. Yeah, any other questions coming in today? We've got about another 5 minutes. Oh, here we go. Just as I was saying it.
Before we answer this question, I will just, sorry, Harriet, I'll just encourage people, now that we have discussed the more broad themes, to ask more practical questions, more specific questions that we can answer, because that can also be useful. Sorry to interrupt.
No, absolutely. I think someone's just done that. So once you sign up for the program, how long do you wait to get the first consultation with the health coach and with the expert clinicians? So most people get seen by a health coach within sort of 24 to 48 hours. It's really kind of up to you. So if you sign up and you're free tomorrow, you can usually get an appointment the next day. If you are busy, you've got to reschedule something, then it could take a couple of days. But the health coaching consult is relatively quick. In terms of the expert clinician, that's usually within about 7 days of signing up. Again, you could get it within a day or two, but it's to manage your expectation. It's usually within about sort of 5 to 7 days. And anybody who is struggling to get that consultation, they just email support, and we can sort that out. But that's the kind of general turnaround time. Another question's come in. If on the medication for years, would the dosage have to be increased largely?
Not usually. So when we reach the maximum dose of the medications that we are using, if I'm answering the question correctly, if we are on the maximum dose of the medication, we just stay on the maximum dose. There is no evidence that the body gets used to that maximum dose, and we have to increase it further.
Brilliant. So it's not like you build up a resistance to
No, there is no
medication.
evidence of resistance.
That's fascinating. And as you said, you know, new medications are going to come along, and this is a really fast expanding area.
I'm going to be very positive here, and this time I mean it when I'm positive that. And I'm going to give you some numbers so that people can kind of orientate themselves as to where we are going with medications. So at the moment, we have got 2 or 3 medications, and the average, remember the word average weight loss that we get is 8% total body weight loss. Remember, people respond very differently. Some people can lose 16% of their body weight. Some people can lose not a single kilogram. And that's nothing to do with you doing something wrong. So the average weight loss that we can cause at the moment is approximately 8%. With the medications that are going to become available to us in 2024, we're going to be able to initially cause 16% weight loss, and then eventually 22% average body weight loss. So you'll see how the evolution of medications is very fast, and the amount of weight loss that we are causing increases exponentially. So 2023 has been a reasonable year. 2024 will be a great year for these treatments.
Wow, really, really exciting times. Final question that is saying, is the medication you prescribe Ozempic or Wegovy, is it hard to get them due to supply and demand?
Great, I think you can take this one.
Yeah, so we prescribe semaglutide, and semaglutide has many different brand names. One of them is Ozempic, one of them is Wegovy. We prescribe within the HPRA guidance, within the NICE guidance, and you know, semaglutide is listed as an advised medication under that list. Yes, there are supply and demand issues, like there are in many other areas. But you know, if somebody is living with a disease of obesity, we take the opinion, like many others do, that no disease is any more or any less important than another. So obesity is no more or no less important than type 2 diabetes, just like, for example, bowel cancer is no more or no less important than breast cancer. And there's much overlap between different chemotherapies, and there's overlap between obesity and type 2 diabetes. So, you know, it's about the safe and effective prescribing. I think that's a really, really important point to make.
To add on that one, if that's okay with you, Harriet, I'll just say that Wegovy, which is the preparation of semaglutide at 2.4 milligrams, is the medication I was referring to earlier on that we expect to arrive in 2024, fingers crossed. And that's the one that causes an average weight loss of 16%. At the moment, is not available in most places, in most countries in Europe, but we expect it to become available next year. And with regards to the supply problems, you have done some great work in making the medication available through other kind of official sources, so importing it from the UK and from wherever supplies are available, and it is exactly the same medication that is available in Ireland, but we are importing from next door.
Great. So I think you know, if that's all the questions, I think we come to the end. I'm really, really delighted that you all took the time out of your evening to join, and I really hope most of you have got the answers to any of the questions that you were, you know, that were burning. You know, what I'd say is we'll be doing more of these webinars. So if there's more you'd like to learn, if there's more ways you want to get in touch, please do. If anybody is considering joining Beyondbmi, what I would say is there's an opportunity to have a free care consultation. In that consultation, there's no obligation at all to join, and it's a really good opportunity to speak to somebody who is also themselves on the program as well. So they're able to talk you through the pros, the cons, you know, what's good, what's not. So it's a great opportunity just to educate yourself, you know, and get, oh, that's a great comment. Thanks very much, SF. I'm glad you're enjoying the program. Yeah, so yeah, if you want to get in touch, just go onto the website and click on the eligibility criteria. Once you get through that, you're more than welcome to book in for a free call. Okay, so that's everything.
Good.
Thanks, Maggie.
Thank you very much. Bye-bye.
Have a lovely evening, guys. Thanks, Emil.